Hello, everyone. Welcome to another Vestibular First Journal Club. Tonight we have with us a very special guest, Dr. Johan Dumas, and he is going to discuss the skull vibration-induced nystagmus test. And before we get started, if you could just tell us a little bit about your background.
Yes. Hi, and it's a great pleasure and great honor, and I thank Elena Simon and the Internal Club to give the opportunity to speak about skull vibration. It is a recent test which we have studied during these 20 last years and collaborations with Professor Curtois for the fundamental basis and a clinical point of view with Professor Schmerber in Grenoble and Professor Perrin in Nancy. And Dr. Sino performed a PhD thesis about its usefulness in children. And more recently, Dr. Armato is preparing a work about SVINT. I know that many of you have already used SVINT, but in this presentation, I want to show why and how it works by showing briefly some neural basis for this nystagmus and with more details, clinical implications on results. My presentation is divided in 5 main chapters. First, concern a short historical context. Second, fundamental animal experiments in guinea pigs, which concerns essentially Curtois experiments and data. Third, the technical condition for skull vibration-induced nystagmus test. Fourth, I'll speak about the main clinical results and main properties in patients with unilateral vestibular loss. And finally, I'll present new data about SVINT in semicircular canal descents and a few clinical evidence which shows that it can be used as a bone-conducted Tullio phenomenon. A short reminder about the historical context. The first to have described for the first time VIN, vibration-induced nystagmus, was Luke in 1973, who accidentally observed in a patient who used a customary device, a nystagmus. This patient had a unilateral vestibular loss. This was confirmed and extended by Carl Friedrich Eman and our group in 1999 and other authors. And this test was the object of a PhD thesis in 2014 in Nancy. And since many publications have been edited on this topic. What is the skull vibration-induced nystagmus? Here it is an example of a severe unilateral vestibular loss. And when one simulates one mastoid, either mastoid, right or left, it induces instantaneously a nystagmus beating away from the lesion side. It is reproducible on both mastoids, and usually mastoid stimulations are more efficient than vertex stimulation. It starts and stops with the stimulation onset and offset. This patient had a disabling Meniere's disease, and it was treated by intratympanic gentamicin.
If the patient has no pathology, they're coming in with no unilateral loss, they should have no nystagmus. Is that correct?
This patient had a Meniere's disease, and he was treated by intratympanic gentamicin. And before the treatment with gentamicin, this patient has no nystagmus, or very mild nystagmus. And when he was treated with 4 injections, transtympanic injection of gentamicin, he had a strong unilateral vestibular loss, which was confirmed on the left by caloric test and DHIT. And when we performed after intratympanic gentamicin the skull vibration-induced nystagmus, it revealed a strong lesional inhibitory nystagmus corresponding to the lesion created by the intratympanic gentamicin. Okay?
Okay. And then even if you tested him 15 years afterwards, would it still be abnormal? If you tested him for years afterwards, would it still show that?
Yes. I will show a few other examples of patients recorded very late what a long-standing vestibular lesion, and in whom the nystagmus is still observable. Here is the recording of this patient. This patient, it is a 3D recording. Here is the horizontal component, the vertical component, and the torsional component. There is the right mastoid, which is stimulated, as you could observe, and the left mastoid and the right mastoid. It is reproducible on both mastoids, and when there is no stimulation here, it stops abruptly, very sharply, abruptly, and it starts again with the stimulation. It is onset and offset, very abrupt. It is very peculiar of skull vibration-induced nystagmus. Further explanation, a fundamental explanation. The observation of nystagmus is due to the asymmetry of neuronal activity between the two vestibular nuclei. That is the usual condition. You have a lesion on one side here, and the activity of the nucleus on the same side is diminished. Conversely, the activity on the contralateral side is augmented, is enhanced, and that the nystagmus beats away from the lesion side and toward the intact side. At the later phase, at the compensated phase, there is a reequilibration of both activity of the activity of both vestibular nuclei, and there is no longer any nystagmus. But this asymmetry can be revealed either by a caloric test, which shows on the lesion side no response, and on the safe side one response. But it can be showed also by the skull vibration-induced nystagmus test, which stimulates by bone conduction. It is very peculiar stimulation. Bone conduction stimulates both sides, and the response, the nystagmus-induced, corresponds to the stimulation of the intact side here on the right side. It is a very peculiar nystagmus. The current, usually in usual vestibular exploration, concern for example, rotatory test or caloric test, concern a cupular mechanism here. In this condition, the cupular deflection is due to rotatory or caloric stimulation. And in this condition here, there is displacement, either by the rotation or by the convection of the caloric test. The receptor is extremely sensitive, and in this condition, displacement of a few nanometers can induce a response, a nystagmus. Conversely, for the skull vibration-induced nystagmus, the vibration, which is at very, very high frequencies, as 100 Hz, this frequency is higher than the cutoff frequency of 60 Hz described by Hermann in 1980, which which overcomes the function of the cupula. The cupula at such high frequencies does not work. And it is a direct stimulation of the air bundle. Yeah. The deflection of the receptor air bundle changes the membrane potential, and the deflection is provoked by the liquid compressional wave created by the vibration at such high frequency. It is very peculiar to the vibration-induced nystagmus.
Is it only stimulating the horizontal canal cupula?
It stimulates. No, it's a global test. It stimulates mainly canals, but it stimulates also triangle, and we will see it a little further. To hand the partition between classical cupula stimulation, in the condition of a rotation or the caloric test, here reaches the condition of a rotation. And in this condition, there is a slow build up and slow decay. Here, there is the rotation, slow build up, and slow decay.
Right.
That is the condition for the caloric and the rotatory test. Conversely, for the skull-induced nystagmus here, the nystagmus starts and stops abruptly. There is no nystagmus build-up, no nystagmus decay as here. It is only an abrupt response on-off, onset, offset. It is due to a completely different mechanism causing the imbalance in neural activity of this two vestibular nuclei. And we will come back to more clinical data. How to perform SVINT? Many of you know. The patient is sitting with goggles, frontal goggles, or video helmets, video mask. The vision is denied on the not filmed eye. The patient is asked to keep a steady midline gaze, and the examiner is either in front of the patient, as on this example, and with the stimulation of mastoids performed on the right, and then on the vertex location. Yeah, vertex.
So the mastoid is the bony lump right kind of behind the ear. Is that yes?
Yes. The mastoid is stimulated behind the auricle at the level of the external ear canal.
Got it. And the vertex is that's the top back of the head is the vertex, is that right?
Well, the vertex is here at the top of the head. This stimulation of mastoids is very interesting for classical UVL patient, unilateral vestibular relation patient with unilateral vestibular loss. And vertex is very interesting in patients with anterior canal descent. We will see it more in detail.
Sure.
The stimulation duration is 5 to 10 seconds. But the stimulation can be performed, the examiner can be behind the patient to use his dominant hand to make the examination more reproducible for recordings, for example. But in clinical practice, there is no big asymmetry when we use the dominant or not dominant hand. It is useful for recordings and for more scientific work to use the same hand. What are the available common devices? We have used during these last years a mechanical off-axis rotating vibrator, which is a manufacturer standard, European manufacturer standard corresponding, and it is the Synapsis and Ventis device. This device is very reliable. It delivers frequencies at 100 Hz, which was the most efficient. We will see it in detail further. And it has a sufficient amplitude of around 1 millimeter of amplitude. But there are many other electromagnetical devices which are also very efficient. The material and platform, the VVS, the airplane can say 72.9 knots. There are many material with Framira more recently. What is essential? It is at least to have a device which delivers 100 Hz because it is the most efficient frequency in unilateral vestibular loss, which it's somewhat different in anterior canal descent a little further. For very high frequencies for research or for the anterior canal descent diagnosis, one may use an electromagnetical device commercialized by Nerum Denmark, which is the Brilliant mini shaker, which delivers frequencies from 10 to 1000 Hz or higher. But that is mainly for research and anterior canal descents. What is most usual, 100 Hz in UVL. More recently, one interesting device has been commercialized by BASM, which use a bone vibrator, which is directed, which is commanded by a Bluetooth link from an iPhone. And on this iPhone, there is a frequency generator where we can command frequency and the amplitude for the vibration. It is cheaper than the Brilliant stimulator, and it delivers frequencies from 10 to 1000 Hz on higher, but it is less expensive. What's important, there are many other devices. There are devices which are customary devices, messenger devices, but we have compared such material with the reference material of Synapsis here. And here is an example of a device, a messenger, which it is very cheap and delivers frequency at 100 Hz, but which was not efficient. Why? That is the reference, and that is the messenger. But for the slow phase velocity. And this material at more than 30% of false negative results. And why? The essential important point is for the material, for the device to have a sufficient amplitude and sufficient acceleration. That is the acceleration, the variation of acceleration with the Synapsis device, and that is the amplitude variation with the natural discovery atom model device. There is 10 times, the variation of amplitude is 10 times higher. Why? Because the inner ear receptor response is very efficient The vestibular receptors work as a seismic captor, which is very sensitive to jerk stimulations, as demonstrated by Curtois. And the reason of acquisition of material of a device is the frequency, but also the minimal amplitude and minimal acceleration. And it has been demonstrated by Diagnostic and Curtois that minimal acceleration are between 0.2 and 0.4 G. That corresponds to an amplitude exposure. What here is one example of long-standing unilateral vestibular loss. This patient had vestibular neurectomy 23 years ago, and the stimulation of either mastoid induces here a nystagmus beating away from the lesion side, from the left lesion. It is reproducible, exactly reproducible each mastoid, and as usually in unilateral vestibular loss, the mastoid stimulations are higher, more efficient than vertex stimulation in UVL patients, and it beats away from the lesion side. In total unilateral vestibular lesion, it is always beating away from the lesion side. That is the recording of such patient with a total unilateral vestibular loss. Patients with unilateral vestibular loss have essentially a horizontal component, a torsional component, but very poor vertical component, and sometimes zero response. The most total is the lesion. The lower is the vertical component. Why? Because in a total vestibular lesion, the safe side is stimulated. And when we stimulate superior canals, the circular canal, it induces a downbeating nystagmus. And when you stimulate an inferior, a posterior semicircular canal, it induces a hot-beating nystagmus. And the two nystagmus are cancelled. Conversely, the torsional components for the superior and posterior canal beats into the same direction. And there is no cancellation for the horizontal canal. And in this case, the nystagmus starts and stops when the stimulation onset and offset is reproducible on the right mastoid, left mastoid. If the recording on the camera is on the right eye or the left eye, totally reproducible. The components in total unilateral vestibular loss, that is work performed in 46 patients, showed a horizontal component observed in 98%, torsional component 70%, and vertical more seldom 45%. There were patients with total and severe, rather with severe unilateral vestibular loss, like as on the first example I showed at the beginning of the presentation, who had so vertical weakening. But there is no total unilateral vestibular loss. What is the skull vibration-induced nystagmus origin for clinician? This is the result of large clinical series published by Dang, about 800 patients with UVL, Fujimoto 800 patients, 80 patients, and our work with Dr. Fab in Grenoble was 65 patients. There is a very strong correlation of the skull vibration-induced nystagmus with the lateral semicircular canal. That we studied this different papers studied the correlation of vestibular with vestibular exploration, with triggered vestibular exploration, which were correlated with structural structures. There is a strong correlation with the superior semicircular canal and the utricle, very mild, very smooth with the posterior canal, and these studies showed, for most of them, no correlation with the sacculus response, CVMP, no correlation with CVMP in most of cases.
So if we want to know if the saccule or the utricle has been affected, we would go back to VEMP testing. Is that correct?
Yes. Yes. This vibrations concerns the all inner spectrum, but the skull vibration-induced nystagmus is evoked, it's revealed mainly with canal structures, superior lateral and utricle structures. There is very bad correlation with sacculus.
Got it.
In this condition, the CVMP are a very interesting test to explore, of course, the sacculus. And the skull vibration-induced nystagmus gives poor results in case of sacral lesion. That was what you wanted to
Yes,
do?
perfect. It's just good because some of the clinicians who watch this are not getting to do all of the vestibular tests because we don't have all of the equipment. So it's good to know when to refer for additional testing. So if I do a vibration-induced nystagmus test as a physical therapist, which I am, I might say this patient might benefit from a VEMP test because I can't tell if the saccule has been affected and I have concern that that could affect the patient's function. So we would want to recommend the additional testing. So it's just good to know when you need to ask for more. Yeah?
Yes, of course. And I will show an example. For example, in case of inferior root in vestibular neuritis, in case of lower inferior root of the vestibular nerve, when it is on this lower part, the inferior root which is concerned, the skull vibration gives poor results, but it is very seldom situation. Most often it is either the upper root or total vestibular neuritis. Most often, and it works very well. It is a good indicator in vestibular neuritis. We'll see it in more detail further. What is more precise? What do we know more precisely with the skull vibration-induced nystagmus? This test reveals instantaneously vestibular asymmetry as a screening test, the first-line test, a bedside test for frequencies about 100 Hz. In case of a patient with normal encased labyrinth, vestibular neuritis, schwannoma, but it is different in anterior canal DHZ, and we will see it later further. This test concerns both canals and otoliths, essentially utricle at 100 Hz, and type 1 inner ear cells as described by curators in animals, type 1 inner ear cells with irregular discharging fibers. And at 500 Hz, it concerns only otolith structures. And in clinical practice, we'll see it more precisely, it is 100 Hz which respond for this SVINT, and not 500. We'll see it further. The nystagmus stem mainly from the structures I have previously described. In this presentation, I will speak only of cranial vibration. I will not speak about I will not consider cervical vibration, which concerns the vestibular ocular reflex, the VOR. Skull vibration, mastoid or vertex concerns its VOR, vestibular ocular reflex, and cervical, the COR. It's very different. It's a different thing. And one main property of the skull vibration-induced nystagmus, it is that it is one of the seldom tests, of the recent tests, which explore the very high frequencies, the spectrum, the superior spectrum of the vestibular frequencies. Also, the VHIT explore the high frequencies at 6 Hz on type 1 inner ear cells. But here at 100 Hz, it is very high frequencies on type 1 inner ear cell. Conversely, the caloric test explores a very low frequency at 0.003 Hz. And in the interval, there is the rotatory test, the edge-checking test, middle range frequency 2 Hz. And the frequencies of the skull vibration-induced nystagmus are some way extra-physiological, since in daily life, the frequencies in daily life are between 0.05 Hz to 5 or 10 Hz. As the caloric test also, which is very low, very far from the natural movements. And a point in some patient with canal lesion, lateral canal lesion, one may observe discrepancies between skull vibration and caloric test. Why? Because caloric test explores very low frequencies on type 2 inner ear cells, and skull vibration explores type 1 inner ear cells. And sometimes in 20% of patients, one can observe either with a patient with horizontal canal lesion, a caloric test which is positive on the negative skull vibration on and the opposite situation is possible. Conversely, one may observe a positive SVINT on the negative caloric test. And the SVINT frequencies are very close to the very high frequencies attributed to otolith structures, 205 Hz, which are measured by electromyographical devices. What in clinical practice, what are the characteristics, the essential features to recognize a positive test? This nystagmus starts and stops with stimulation onset and offset, as previously mentioned. The nystagmus is sustained, continuous. There is usually in UVR patient with unilateral vestibular loss, no after nystagmus. We'll see further that it's somewhat different in anterior canal descent with fistula. And the response is reproducible in both mastoid, the same direction, is consistent, and the slow phase velocity is usually higher than 2.5 degrees per second. If only 2 of 3 or the 3 characteristics are observed, the result is dubious. How to report the results? Usually, most useful frequency is 100 Hz, but some devices deliver 60 or 30. That is the result on right mastoid left mastoid on the vertex, here is an example of a right peripheral vestibular lesion, vestibular neuritis, for example. And the intensity of the response of nystagmus is noted with crosses. One crosses the low response, three crosses high response, and the IN direction is indicated by one arrow. By analogy to the conventional indications of audiological Weber test, the arrow, the direction of the arrow shows the quick phase of the nystagmus. What is the optimal frequency? That is the result of the work which we have published in European Annals and United Via-HNS. We performed this stimulation in 15 severe ulnar lateral vestibular loss, and the 100 Hz frequency is significantly more efficient in patients with unilateral vestibular loss. There is no response at 500 Hz for the skull vibration-induced nystagmus, and quite nearly almost no response at 10 Hz. It's the value is on the cutoff for normal is about 2 degrees per second. What is the optimal topographic stimulation? Why? We have compared stimulation. We have studied the slow phase velocity in 34 patients with a severe unilateral vestibular loss, that is intratympanic gentamicin, vestibular neurectomy, and intratympanic and vestibular neuritis. And we have tried the mastoid location, the cervical upper part location, that is to say 2 centimeters below the mastoid, the cervical lower part, that is to say the very posterior and inferior part of the trapezius, the vertex, and the anterior part of the cervical region. And the values of the slow phase velocity of the horizontal component were not significantly different for the mastoid and the upper part of the cervical region, 2 centimeters below, probably because there is a transfer transfer of vibration, but they were significantly higher than the cervical lower part, and were significantly higher than for the vertex and for the anterior cervical region. To summarize, and to give to clinicians the optimal values for skull vibration, we have, and for what concerns the horizontal component, in TUVL there are 2 different things. What I have showed is in TUVL, total unilateral vestibular loss, transadventine approach, neurectomies, and SUVL. And on the other part, there are the results which are very different in superior canal descent. We will see it in the second part of this presentation more in details. For TUVL and SUVL, mastoid stimulation are very efficient, more efficient than vertex, significantly. 100 Hz is optimal, but one may observe good responses between 60 and 120 Hz. The slow phase velocity is around 10.7 degrees per second. Conversely, in superior canal descent, we'll see it in detail further, the vertex stimulation are equivalent to mastoid. And sometimes at 100 Hz, vertex stimulation are more efficient. And there is a translation of optimal frequencies toward higher frequencies. Optimal frequencies are around 400 Hz, but one can observe good responses at 100 or up to 700 Hz. And slow phase velocity is lower, 4.5 degrees per second.
Okay, I have a question, if I may.
Correct.
So I have had a patient who had a cerebellar stroke.
Mm-hmm.
And if you do this test on someone who's had a brain vestibular issue, multiple sclerosis, or a cerebellar stroke, might you see a nystagmus? What could you expect?
That's a very interesting question. I show one example. These in central lesions, usually there is no response because most of them more sensitive to explore peripheral lesions than central lesions. However, in some rare cases of central lesion of the brainstem concerning the vestibulocular reflex at the very close proximity or vicinity of the nuclear vestibular nucleus, or on the root of the eighth nerve, or in the nucleus of the eighth nerve, it can be positive. I will show you a case of multiple sclerosis where this test was positive, but it is very seldom, and the lesion must concern the vestibulocular reflex, very precise lesion on the vestibulocular reflex. It's very seldom observed. In case of, to answer you, in case of cerebral lesion, usually there is no response, but when cerebral lesion can modify sometime the vestibulocular reflex response, modulate it. What is sensitivity? Sensitivity in total unilateral vestibular lesion was 98. In transabdominal approach or vestibular neurectomies, we had a series of 131 patients. And VIN in this condition is always beating away from the lesion and toward the intact side in 10% of the case. In partial unilateral vestibular loss, vestibular neuritis, chemical labyrinthectomy, intratympanic gentamicin, preoperative Schwann-Armenias disease, sensibility was 76% in a series of 84 patients. And in this condition, the IN beats away from the lesion in 91% of cases. And the specificity has been studied in 95 normal subjects, was 94. In one other series from Zamora, concerning 122 normal subjects, it was 79% for specificity. The large series of patients studied by Zine 2021 showed specificity higher than 80%. And what were the now we come to the clinical interest and to the results in clinic. What is the main point, main property is that VIN SVINT is not modified by vestibular compensation in patients with total unilateral vestibular loss or severe unilateral vestibular loss, that is, in patients with permanent lesions. The test is always, when the lesion is there, the test is always positive. The lesion there. Here is an example of a long-standing temporal bone fracture, which occurred 10 years earlier. And this patient revealed a lesional inhibitory nystagmus when stimulated on the right or left mastoid. This may be interesting in occupational or medical legal forensic medicine, for example. Here is an example of long-standing vestibular neuritis consulted for BPPV. And this patient had only one jerk at the HIT, but the SVINT revealed still a persistent lesional inhibitory nystagmus when mastoids were stimulated. This patient had vestibular neuritis, a long-standing vestibular neuritis, which concerned the superior root of the nerve, that is, this anterior canal, lateral canal, and caloric test was modified on the left side, but the CVMP were preserved, and the angiogram was normal, and the posterior canal was preserved. In vestibular neuritis, there is a strong correlation of the horizontal component of skull vibration-induced nystagmus with the tests which explore the horizontal canal function. For example, in a series of 42 vestibular neuritis, the skull vibration-induced nystagmus slew phase velocity was very well correlated with the caloric test hypofunction in person. There is a correlation on the regression graph. It was the same observation with the horizontal, with the lateral VHIT. Here is the lateral VHIT percent of asymmetry. Here is the slow phase velocity of the SVINT. There is a strong correlation. But this test is positive also in patients with progressive compensation. There is a schwannoma, voluminous schwannoma, and this patient, when stimulated on the right mastoid, shows an inhibitory nystagmus beating around your right. As well on the right or the left mastoid. The sensitivity in schwannoma is observed in 71% of vestibular schwannoma. And the caloric test in our series, 70 patients, was positive 87. But this test is most often positive in voluminous, large schwannoma stages 3 or 4, as in the series of Lee, which was on about 13 patients, was positive 93%. In smaller lesions, stage 1 or 2, which is positive only in 60%.
So if the lesion is irritating the nerve, could the nystagmus ever beat toward the lesion? Does that happen as well?
Yeah, you want to tell if there is sometimes one irritative nystagmus. Yes, it has been described, but this is very seldom.
Seldom, okay.
There is a series of Negrovern who found it in around 15%, and there is a Spanish series which showed it in a certain number of cases. But in my experience, our experience, and in other experience, it is very seldom to find, to observe an excitatory nystagmus in schwannoma. Most often, it is inhibitory.
Got it.
And in Meniere's disease, at proximity of a crisis, in Meniere's disease, most often one observes an inhibitory nystagmus, but an excitatory nystagmus may be observed in 15% of cases of Meniere's disease. Here is an example. Left Meniere's disease, normal VHIT as usually, slight, very small vestibular preponderances and the caloric test. And this patient had no edge-shaking nystagmus, but when vibrating mastoid, one observed one excitatory, irritating excitatory beating toward the left, toward the lesion. It is possibly in vestibular pathology, in peripheral pathology, the most frequent fluctuation where we find usually an excitatory nystagmus. Hong found an excitatory nystagmus in Meniere's disease in 27% of his patients, and conversely, TG in a large series of Meniere's disease observed only an excitatory nystagmus only in 2% of his patients. In Meniere's disease, what is interesting is the control after treatment, invasive treatment by intratympanic gentamicin after in patient with disabling Meniere's disease. Here is a patient with right Meniere's disease for disabling, and he had 4 injections of gentamicin. And this is observed, he had a good result, and this is the exploration 4 years after the gentamicin. He no longer had any vertigo, any crisis, any attack. Etching test shows lesional inhibitory nystagmus beating away from the lesion and toward the intact side on very fast, very rapid vibratory nystagmus, also inhibitory nystagmus. Poor response as vertex. And the HIT confirmed strong deafferentation after gentamicin, efficient in a patient, a responding patient. Other clinical interest of the vibration-induced nystagmus, it is that it complements other tests in the very high frequencies exploration. And here is an example of a patient who had an incomplete bilateral vestibular Areflexia, major chronic unsteadiness, oscillopsis. The rotatory test shows no response in the 2 direction. And the vibration-induced nystagmus showed on the same day, in the same consultation, instantaneously, that there is a strong right beating nystagmus corresponding to the fact that there is at least on the right side remaining cells responding to very high frequency.
Mm-hmm.
This could be confirmed by a more precise analysis of the frequencies. This patient at the caloric test, no response outcome could be identified via direct. On the VOR, via rotatory test, VOR1, VOR2, no response. Of course, VVOR, no response, vestibular. But on the VHIT for high frequencies, there were very poor response on the 6th semicircular canal, with gain lower than 0.05%. For the very high frequency, no response for the VHIT, for the CVMP, but for the SVINT, there is a strong right beating nystagmus, which starts with stimulation and beats toward the right, and suggesting that there are remaining inner ear type 1 inner ear cells remaining on the right side. And this could be confirmed later with OVMP, which were preserved on the right side with conduction. This patient had a labyrinthine MRI, which showed on the right side one utricle, observable, identifiable, but was absent on the left side of this patient. Last property in clinical practice. This test acts as a vestibular Weber test. This is one analogy. It is useful in SCD diagnostic. I have showed that in the previous examples that most patients with unilateral vestibular loss deficit lesion have a nystagmus which is most often beating towards the safe side or away from the lesion side. And in SCD patient, it is very different. In this patient, nystagmus is most often when vertex is stimulated, most often beating towards the lesion side. We will try to see why. On this test, it can be interpreted as a bone-conducted Tullio phenomenon. I show you why. What do we know from physiology? This is the result of the studies from Merchant, Rosowski, and Sanger, which shows that when there is a third mobile window and superior canal descent, the bone conduction is facilitated toward the lesion side. Second, Curtis showed that in case of anterior canal descent artificially created here, there is an extension of response toward very high frequency. Here it is before the creation of the descents. There is no, there are no tuning curves, no action potential, no tuning curves. And when the descent is created artificially, air conducted sound and air vibration, bone vibration, there are tuning curves response. And he remarked that semicircular canals, the anterior semicircular canal, which had not responses at 100 Hz before the descent, had suddenly responses for very high frequency at 100 Hz. There is an extension of sensitivity toward very high frequencies. This is observed already with CVMP in clinical practice. Very high CMMP show sensitivity to very high frequency, OVMP, or OVMP extension in anterior canal cells. And the conception from Evenson and Rabbit allows to understand better the Tullio phenomenon. They performed experiments in toadfish, which they created artificially descent, and they studied mechanical modifications at the level of the endolymph, and they observed first that at the level of the descent there was a pumping mechanism which induced an endolymph flow. And this flow, the direction of this flow, depended on first on the side of the descent, but also on the location of the stimulation, and also mainly on the frequency of the stimulation. And here it is a flow, an ampulofugal flow, and here is this one at another frequency, an ampulopetrol flow. And he correlated this mechanical constatation to electrophysiological recording. In here, it will recording on regular discharging fibers at the level of the ampular crest. And for low frequencies, lower than 500 Hz, he had an excitatory response. And for frequencies higher than 500 Hz, he had an inhibitory response. Yeah, and that's true for higher frequencies, again, excitatory. And to simplify, that is a simple modularization of the concept, which I present with the authorization of purpose. There is at a certain point and certain frequency, the flow is in one direction and it reverses at another frequency at another location. That is the principle. And the last observation from a recent work from Kyoto, published in 2023, This author showed that there is a competition between two mechanisms. First mechanism concerns the stimulation of type 1 inner ear cells on irregular discharging neurons here. Starts stimulation here. This is discharge. But this, in a second time, this discharge, this response is inhibited or silenced by the response, which comes later, of the copula, of the copular flow. The second, due to the flow of the endolink on the copula. And that is the response of type 2 inner ear cells on the regular discharging fibers. The response here is opposite, inhibitory. Do we find a similar phenomenon in humans? Those that correspond to what is observed in humans. There is a right superior semicircular descent, and Mastwit showed poor response, but the vertex stimulation shows strong responses. It is a right descent, and the Nystagmus is right beaten, ipsilaterally beaten. It is very different from what we have observed with the UVL formerly before. And here is another example. It is, in this case, it is a left anterior canal descent with a small conductive hearing loss. And the stimulation of vertex up, no, up, move. Oh, yes. No, not sure. Wow. This patient had acid. Oh, yes. The stimulation of vertex showed an ipsilaterally beating Nystagmus. Vertex stimulation are very efficient in anterior canal descents. It is very different from what happens in UVL patients. And it is beating ipsilaterally to the lesion. This patient has had, as usually, CVMP, which were in high amplitude and low threshold. It was similar with OVMP, high amplitude, low threshold. And the Weber in this patient, the vestibular Weber, is beating toward the same direction as the audiological Weber, toward the left. And what that is, how to interpret it. In this patient, there were three components. And there is one vertical and torsional component. The vertical and torsional component correspond to the stimulation of the anterior canal, the descent anterior canal. But there is also a strong horizontal component, which may correspond either to the stimulation of the horizontal canal. There is a often it's quite a spray to the horizontal canal vibration, has been described by other authors, and or to a response of the utri. The vibration is the vertex vibration stimulation is transmitted via the brain on LCR and CSF, cerebrospinal fluid, toward the descent, which is a fistula, a middle fossa fistula. And the vibration is transmitted to the copula, but also to utri. This transmission, special transmission by the fistula or superior on the roof of the temporal bone, may explain the difference of efficiency between vertex simulation in SCD and the low efficiency in usual UVL patient.
And the
There is an example.
Tullio, sorry, just one quick question. Could you just remind everyone who maybe is not as familiar, what is the Tullio phenomenon that was on that slide?
Oh,
What is
yes.
happening there?
Oh, yes. The Tullio phenomenon. Okay. It was observed first by Tullio in animals when he performed small descents in the inner ear, lateral or superior canal, and he used air-conducted sounds. And the experiment I have showed from Everson and rabbit used air-conducted sounds, but also vibrations in the Everson experiment. But Tullio used sounds, and he observed that these animals had body displacement, and they had ocular movements. And it was initially described in human, then with strong low frequency, around 700 Hz air-conducted sounds, and high amplitude, 90 to 120 dB, very high intensity. And this patient with an anterior canal descent described sometimes when they are in nightclubs or when they are submitted to strong sounds, vertigo or dizziness. And it is a very important clinical sign to oriented toward the diagnosis of superior canal descent, but it is not specific of superior canal descent.
Right.
It is observed in most of the third mobile window syndromes. It's not specific. I go on with my presentation.
Yes, perfect.
And it's in this condition, here is a left anterior canal descent here, and this patient stimulated on the vertex, which is SCD's most efficient location. In some patients, 14-15% of our patients, we observe that VIN is maximal when the gaze is directed in the plane of the superior canal descent. Oh, yes. I hope it will work. No. No, does not work. Sorry.
No, that's okay.
It was in this condition, the nystagmus was this. It was down between and torsional. This patient, the left descent, torsional, beating ipsilaterally toward the left descent canal. And this corresponds in this condition to a pure simulation of the superior canal descent, the descent superior semicircular canal. Physiological has been described like that by Cohen Suzuki. Well, that's not important. What we have verified in our series is also the extension of sensitivity toward very high frequency. Here, which has been described in animals by Körpers. Here is this patient was stimulated at 100 Hz, and there are poor response. But with stimulation at 300 and 400 Hz, there are very strong response with three components. Here it was a left descent. There is an extension. As it is the same observation with OVMP and CVMP, extension toward very high frequency sensitivity. One other patient responded up to 700 Hz. This is never observed. This is never observed in UVR patient. No UVR patient respond at such high frequencies. No 400. It's very specific third wave syndrome patients. And what we have observed also is the results of described by corresponding to the result described in animals like Everson. The nystagmus direction depends on the location of the stimulation. There was the right mastoid stimulation, 100, right mastoid, right nystagmus. Here is the left mastoid stimulation, left nystagmus. And there is the vertex, which is usually most efficient. It was also left stimulation. There is the slow phase velocity, no stimulation, right mastoid stimulation, corresponding to the right nystagmus, slow phase. And there's the left mastoid, and the vertex was choose slow phase toward the right, and the nystagmus toward the left. And what we observe in 20%, 25% of our patients is that just we stop the stimulation and nystagmus is still going on. Yeah, that is one after nystagmus. This is very specific, very interesting. This is due to the fact that the cupula, it is a properly cupular response as what is observed with a rotatory test or with the caloric test. There is a deflection of the cupula, and this is represented by this after nystagmus. This is the second response. What is also corresponding to physiology is that in a certain number of cases, also around 25, there is a direction changing nystagmus following frequency. So here the example of a vertical component. There is a beating vertical component at 60, 100, 200 Hz, upbeating. And when the stimulation is at 300 Hz, it becomes downbeating. That is also regularly observed in anterior canal descent. To summarize these results, we have compared in a series of 39 patients explored with Castellucci. Our result with 38 patients explored by Meta, and which was published in Otoneurology. And in our series in red, SVINT positivity was observed when vertex was stimulated, was observed in 90%. And the nystagmus, vibration-induced nystagmus, ipsilaterally beating toward the lesion was observed in 82% of cases. The nystagmus changed of direction following the location, right mastoid, left mastoid, changing mainly different of mastoid. The vertex stimulation is referential, and changing of direction is observed in around 55% case. And the changing direction following frequency is observed in our series in 25%, and when after nystagmus observed 25%. And in patients where Tullio phenomenon was studied, the air with air stimulation, and the another test was studied the pressure. In the test, it is a pressure pressional test with the compression of tragus or with air compression in the air with the Pulitzer peer. It was the sensitivity was only of 35% and 30%, and in meta works who stimulated his decent patient only on mastoid process. He observed the sensitivity of the test in only 55%, And when he compared his results with the Tullio test he performed and the Engelbert test, it was more sensitive with the SVINT test. It is possible that in clinical practice, SVINT is possibly more sensitive than the Tullio, classical Tullio, and the Engelbert test. This needs further works. And in literature, the sensitivity of the test is between 55 for Meta and 100% for Manzari. And in literature, previously, authors have already described discrepancies following location of stimulation for the direction of nystagmus. This was already described by White, and mainly by Manzari in a large series of 16% patients. Very frequent discrepancies right and left mastoid stimulation is 60% of this patient. What happens in bilateral lesion? Most often the nystagmus is beating towards the most distant side, or where there is the most important hearing loss or the symptoms. Here is the bilateral lesion in which nystagmus is beating toward the left because it is predominant in the left side. And in this observation of a patient who had disabling symptoms and was operated on, which is before surgery, he had the right side. When he looks toward the left, the gaze is toward the left, there is a vertical down beating toward the left. It was the left distance. And this patient was operated with plugging and the resurfacing with some boom. And post-operative results show the disparition of the symptoms, but not of the hearing loss. And but he had a strong otophonia before surgery, strong otophonia and a vertigo, and there is no longer any nystagmus. Is this test interesting does this test has a topographic interest? No, not much. VIN is not specific to a location on the DO pathway. This is to answer to your previous question. However, it is significantly more frequently observed in peripheral than in central pathologies. There is a pure, strict peripheral lesion. There is a malformation of the semicircular laterals, horizontal semicircular canal, common cavity, and this patient showed pure horizontal lesional inhibitory nystagmus, left beating nystagmus, no vertical component. This patient had normal vertical canal, posterior and anterior canal. And in central lesion, it is rarely observed. Here is an example of multiple sclerosis of the pons with a recent attack. This patient had an echo signal here, T2, and MRI GADO, which was a recent multiple sclerosis. And this patient had symptoms which were mimicking a right menial disease. Hearing loss, hypofunction in the caloric test, but the BERA, brainstem evoked response geometry, showed no response on the right side, dysynchronization, normal response on the left side, and the skull vibration-induced nystagmus showed a response at 100 Hz, a lesional inhibitory nystagmus. You wanted to ask something, perhaps?
No.
Yes.
I it's not related to this slide. I've been thinking hard about a question we got in the email, whether you would see any nystagmus if you did this test in someone who has BPPV going on either side, or do you expect no nystagmus there?
No, I don't remember exactly, but she had no spontaneous nystagmus. No spontaneous nystagmus. She had a small positional nystagmus. Okay. But she had a hearing loss. at the acute period. Very, tricky, very tricky exam.
Yeah.
She had a lumbar puncture, of course, positive electrophoresis.
If a patient does not have MS, but they have BPPV, and they do not have a unilateral loss, they do not have anything else but BPPV,
Yes.
do they ever get nystagmus with this skull vibration?
Yes. Very interesting point. Yes. Usually, in idiopathic BPPV, there is no vibration-induced nystagmus. But in Lindsay-Manway syndrome, Lindsay-Manway is a syndrome which associates initially vestibular neuritis, unilateral vestibular loss, and a few months or years later, BPPV. And in case of Lindsay-Manway syndrome of not idiopathic BPPV, secondary BPPV, you may find in Lindsay-Manway syndrome, we always find skull vibration-induced nystagmus. If the vestibular deficit is still measurable, if there is no recovery of the vestibular neuritis, which may happen in 18% of cases, around 19% or 20% of cases. Yes?
Perfect. Thank you. Yes.
In any way, the IN is more accurate to reveal peripheral than central neurological disease. That is the result of a study in peripheral unilateral vestibular loss, partial vestibular loss, that is the exploration of the skull vibration-induced nystagmus, and they compared with brainstem lesions, which were essentially vascular disease or multiple sclerosis here. And it is significantly more sensitive to reveal, to unravel peripheral vestibular disease than central disease. To summarize, and the first overview, that all the results were compared, the results in normal subjects here, results in UVL patients, severe unilateral vestibular loss, that is vestibular myectomy or vestibular neuritis or intratympanic gentamicin here, and here in unilateral descent. And we have explored all these patients with the Brilliant gel stimulator with frequencies from 10 to 800 Hz. And we have recorded these patients with 3D recordings, three-dimensional. And we have represented here the horizontal component, the vertical component, the torsional component. In normal subjects, response are very seldom, and they are not reproducible. And in any way, the slow phase velocity is lower than 2.5 degrees per second. In severe unilateral vestibular loss here, its response are essentially horizontal component. Very poor vertical component, often zero if the lesion is very severe. And mastoid stimulation, green and yellow, are more efficient than vortex stimulation, very significant. And responses are elective at 100 Hz. No responses at 400, 500 Hz, nothing. Conversely, in unilateral superior canal descent here, responses are equivalent for the horizontal component, vertical component, and torsional component. And the most efficient frequencies are extended around 400, 500 Hz, very high frequencies. And here, vortex stimulation here are as efficient as mastoid stimulation, and for 100 Hz, often they are more efficient than than for the SUVR. Just to show that with rock curves, the 100 Hz on mastoid in SUVL is very efficient here for unilateral vestibular loss. 100 Hz mastoid, poor results in vertex. Conversely, in USCD, in anterior canal descent, here vertex stimulation at 100 Hz are efficient, and 400 Hz is efficient as for the crab mastoid and for the vertex stimulation. To end this presentation, what is the essential? SVINT act as a vestibular Weber test. In the condition of total unilateral vestibular loss, here represented, the nystagmus beats toward the intact side or away from the lesion side. The vibration stimulates the intact side. In partial unilateral vestibular loss, the nystagmus beats toward the most excitable side. And in SCD, in superior canal descent, in this condition, there is a bone-conducted facilitation toward the lesion, and the nystagmus beats most often toward the lesion side. And to conclude, this test is useful to authenticate pathology as a screening bedside examination test. SVINT must be part of the armamentarium of systematic first-line tests. It shows vestibular symmetry in not only in unilateral vestibular loss, but also in asymmetrical bilateral vestibular loss, as I have showed to you, concern very high frequencies. It is a robust test. It is a good indication of a lesion side in the context. It is more sensitive to reveal peripheral than central disease. It's not modified by vestibular compensation in severe or total unilateral vestibular loss. In case of permanent lesion, just a data in a few vestibular neuritis which recover their function, it becomes negative in time. But when the function is not recovered, it is still positive. And it is well correlated with canal or utricular lesion. In SCD, it is very interesting in diagnosis. It can be considered as an equivalent of a bone-conducted Tullio phenomenon. And to give a final take-home message, SVINT is a fast, simple, safe, robust, sensitive, and specific indicator of imbalance between the two peripheral vestibular systems. It is interesting as a first-line test, and it's now interesting in anterior canal descent diagnosis. Thank you.
Oh, wonderful. Thank you. That was excellent. I do have one more question, and then we will wrap this up because I'm sure we're at our hour. But I had someone ask me whether if someone had some damage to both sides, and you kind of mentioned a case like this, but one side is stronger than the other, meaning there's still preservation. We have some function, at least on one side, and partial. So it's partial bilateral loss. Might we see then this test also show nystagmus towards the stronger side? Yes?
Yes, absolutely. In the case I have presented with this patient who had a metallurgical pathology, who had chemotherapy, and who had an infection with a neurotrop virus. She had a apparent bilateral vestibular areflexia. She had oscillopsis, unsteadiness, no caloric response, no VOR rotatory response, low frequencies, but she had at very high frequencies at an asymmetry, and there were still responding cells on the right side on this patient, which was showed by the Nystagmus, the IN beating toward the right side, and which was showed by preserved OVMP on the right side, preserved high frequencies on one side. That are partial patients as you described.
Yeah.
Partial patient. Yeah.
So in order to differentiate a standard bilateral from a partial bilateral from someone who's a true unilateral, the best combination would be this test plus your head impulse test, and then perhaps even a rotary chair if you really want to kind of pin it all down. Is that yes?
Interesting, very interesting. Yes. Now the recent orientation, the new insight is toward the vestibular implantation. And it is very important to recognize total bilateral vestibular lesions before having one indication of vestibular implantation. And that is very important. The DHIT explores type 1 inner ear cells, but only canal type 1 inner ear cells. And I had not time, but I had one example of a patient with a small, this is one other context, with a small schwannoma on the superior root of the eighth nerve, which he had normal calorics, normal VHIT, but a positive SVINT. Why? Why? It's only because SVINT is a global vestibular test which simulates not only canals, but a triangle. And the response in this condition is probably a utricular response, because the VHIT was normal. And in case of bilateral lesions, to come back to your initial question, of course, VHIT, if it is negative, there is no response on both sides. That only means that canals are normal. But you may have, in this condition, positive SVINT if there are preserved response on the utricle. And it is necessary to confirm the bilateral total areflexia by CVMP, OVMP approach. I hope to have answered your question.
Yes, perfect. Yes. Very good. All right. Well, I think that does it for our journal club this time. And I am so grateful to have you with us. You have done a beautiful job. And this is very helpful for clinicians who are looking for more bedside tests to help them make decisions and to know when to refer for more testing versus when it's not necessary. And so we like tests that can help us with that at a bedside level using our goggles and our vibration tools. So this is awesome. And we thank you so much, Doctor. And I will say goodbye to everyone. I'm Helena Esmond, physical therapist with Journal Club for Vestibular First, and we'll see you next time.
Thank you.